if I could get everyone to have a seat. Pedro. I'm just going to start talking. That way people will be more incentivized to sit down and join us. I'm going to welcome everybody to the 22nd annual ISAP meeting. Thank you very much for coming. It looks like we're going to have a fantastic crowd. I will apologize for a very aggressive meeting schedule. I want to keep everyone on schedule, so even my 5-minute introduction time that I've already expended is already gone, so I'm not going to dwell on things. I want to thank our exhibitors that are next door. They really are important for supporting the meeting. So whenever you have a break, I want you to support our supporters. And that'll be my major pitch for the day. I want to develop a long-term relationship with our supporters so we continue to function as a great meeting in the future. So again, please get to know our supporters well. I'm going to keep my introduction short today. Hopefully you'll all get a chance to speak with the speakers throughout the day. We're a nice small family, and I'd like everyone to know everyone else, and especially our speakers. So I'm not going to dwell on long introductions. Dr. Manfred Blobner has come all the way from Germany. Talk about a drug that we'll hopefully see more of in North America, that I wanted to have someone with more experience than us North Americans with. I will say that if some of the lectures look disjointed, and it's like, how does this all fall together? If you want to quiz me sometime, there actually is a connection of all the theme of the day. And it's a little carryover from last year, and so it was actually to bring things together a little bit from last year, from the NIH and the FDA stuff last year, and I'm still trying to keep that theme going of new drugs, new themes, and new ways to use drugs. So, Dr. Blobner, you're up.
Yes, good morning, everybody. Thank you very much for inviting me to this lecture. It's definitely a pleasure for me to speak to an audience full of experts of pharmacology, because I'm more a clinical anesthesiologist, and accordingly I will focus definitely on clinical pharmacology. So that means on pharmacodynamics, first of all. Some slides in my talk will, of course, try to underlie our clinical knowledge about this drug. So I'm asked to talk about options and risks, and that's exactly what's the structure of my talk. One additional item I put on the list is the limitation of the available drugs so far. I think it's important to talk about these limitations in a few slides, because they make us clear why we have options with the new drug Sugammadex. So, what are the limitations of the cholinesterase inhibitors? First of all, they are ineffective in reversing deep neuromuscular blocks. I think this is a very important issue, and I will come a little bit closer during my option part of the talk. The next thing is the very slow onset. I think 7 to 10 minutes of time to maximum effect is definitely too long at the end of anesthesia, and this is another important limitation. Then the unpredictable efficacy of cholinesterase inhibitors. I've brought you a very informative paper. It's still 10 years old, and in that paper, Kim and colleagues showed that the time between administration at count 1, 2, 3, or 4 to complete recovery in the medium is not the problem. The real problem is that huge variability that doesn't allow to predict if the drug in a specific patient is working or not. So the consequence of this worse predictability is a high rate of residual blocks in clinical practice, even in those countries in which neostigmine or pyridostigmine is given on a routine base. So what are strategies to overcome these limitations? And it's a pleasure for me to show you the very big difference in using cholinesterase inhibitors between your country and the one I'm working in. Cholinesterase inhibitors, due to the limitations I have presented, are very seldomly used in my country. So anesthesiologists try to have a spontaneous recovery controlled with whatever they can, evidence-based, but also the experience. And finally, they tend to prolong anesthesia, all to avoid these drugs that are not really predictive in our view. Okay, what people are doing here, I hope I can bring it correctly. And finally, the solution may be Sugammadex that also overcomes these limitations. So, one obviously in Germany very important reason not to use is the risk that you can give neostigmine if you do it on a routine base to patients that not really need it. With other words, if you have a non-monitored patient and you administer neostigmine, it can happen that the patient has spontaneously recovered. And this is not of any importance because there are, I think, important data published by Frau Herbstreit, working in Boston in that time, now in Essen, she showed with a group that giving neostigmine in a patient that has still recovered 0.9 decreases muscle function, especially the swallowing function, and irrespectively the reason that's behind this administration of neostigmine, the result is always the same. Here shown that neostigmine reversal increases the collapsability of the upper airway. This is the pressure, the negative pressure necessary to lead to a collapse in the upper airways. And in baseline conditions, you need minus 50 centimeters of water in order to provoke such a collapse in the upper airway. At TOF 0.5 in these volunteers, the group needed minus 20 centimeters in water. After spontaneous recovery, over 0.9, close by baseline values have been reached. And important, if you give neostigmine after spontaneous recovery in these volunteers, neostigmine resulted in a higher risk for collapse of the upper airway. This is one of the reasons not in our culture not to give every patient neostigmine, beside others too. So, but let's look to another reason to have problems with neostigmine as the one and only drug to reverse neuromuscular blocking agents. These are data from Grosse Sundrup, again from MGH, collected in 2010 and 11. And what they found is that if the outcome is some kind of respiratory dysfunction, then they found that the risk is definitely not decreased if neostigmine is administered. Even more, it's in some parts increased if neostigmine is given. So this population is typical for what you're doing in America. A high dose, it was given 2.5 milligrams to 5 milligrams per patient. The numbers on the bottom of this slide are numbers from a German survey in which we have tried to show if there are pulmonary complications within the first 28 days. And here you can see what I said, about 5% of the patients, less than 5% of the patients received neostigmine, but in a typical dose, like we do it in our country, it was 0.5 to 1 milligram. But the result was the same. The number of pulmonary complications was definitely not decreased by reversal. It's partly or in tendency, it was slightly increased. In consumption, irrespectively, if you give high doses or low doses of neostigmine, the outcome-related variables are not improved by doing so. So the consequence, the one and only, is as this drug is not helping us to improve our outcome related to post-operative residual colorization, we must hope that Sugammadex can help us out. So I think all of you know Sugammadex, so this only slide that makes the mechanism of the drug easily to see is, I think, very helpful, but I'm sure you have seen this slide about 10 to 20 times so far. It shows the perfect fit of rocuronium in this circular molecule, and the positive charge of the rocuronium molecule is captured by 8 arms with a negative charge, and the result is an electrostatic interaction, van der Waals forces, and all of them make a very firm complex in order to pull out rocuronium from the patient's blood and also from the effect site. Sugammadex by itself is not metabolized, has a plasma half-life time of about 2.5 hours. It is almost entirely renally cleared. The clearance of Sugammadex is close to creatinine clearance, or with other words, the first pass Sugammadex arrives the renal organ, it will be filtered. There is a linear kinetics, and the low plasma and protein and aerocyte binding makes it definitely easy to understand. And now, coming to the dose recommendations, I think this is what people in clinical work are focusing on. The most often recommended dose is a dose for reversal of a moderate neuromuscular block, that is reappearance of the second out of 4 twitch responses. And there is a dose-finding study showing that 2 milligrams of Sugammadex is effective, and the comparative study has proven that in comparison to neostigmine, that Sugammadex is much more effective than the available drug in principle. So the next dose recommendation is the deep neuromuscular block, and there is also a dose finding and a comparative study resulting in 4 milligrams and an immediate reversal scenario. That means 3 minutes after administration in an intubate, can't ventilate situation, suggests 16 milligrams per kilogram. And of course, a comparative study is not really available. I think the one that we have seen are, first of all, dose findings, even as Lee has shown that in terms of an addition of the times, Sugammadex is more effective. The organizational issues of that procedure is still not investigated. So there are some other doses. They are still not recommended, primarily as there are only dose-finding studies, but no comparative one. And so these doses are not recommended by in a scientific session. I think we have to consider these dose recommendations too. The next one is at TOF over 0.2. This is an abstract shown in this Congress 2 years ago, and still published is the dose finding for TOF over 0.5. And you see from all these dose-finding studies that there is a clear relation between the depth of block on the one side and the dose for Sugammadex needed for a complete reversal in all these studies, for a complete reversal within 2 minutes on the average patient and within 5 minutes on 95% of all patients. So, and now to the risks. The risks are, let me say, very theoretical, because who the hell will give 32 milligrams without anesthesia? I think it's very theoretical. I think important are these when frequent there occurs Re-Curarization following not recommended doses. That means to low doses in relation to the block at which the Sugammadex dose is given, and very seldom, you cannot completely exclude, it's about 1,000 or 1 to 5,000 that shows Re-Curarization in a minor amount, even if you have given the recommended dose, but even more important because they have led to the non-approval by the FDA, hypersensitivity, and increase in INR or APTT. These two seldom side effects, hypersensitivity and mild side effects, have led to non-approval by FDA. But in my opinion, there is an additional risk of Sugammadex, which is not pharmacologically related, it's more politically, because again, FDA doesn't allow you to use it. And this is a risk, I think, because the drug is very effective. But also in Europe, we cannot give it to all our patients, because if we would give it to all our patients, we would pay for Sugammadex in an amount that forces us to reduce the people working in our departments by 1/4. So around is the limitation. So these are, in my opinion, the most important risk of the drugs. And so it may be that you understand that from a European perspective, we definitely are a little bit unhappy that FDA haven't approved it, because then you would help us to come in this price discussion too. So now let's come to the serious side effects. Re-Curization. Under Re-Curization, we understand the situation in which a patient has completely recovered to a TOF value of 0.9, but after that, he comes down to TOF values below 0.9. This is an original trace from a dose-finding study done by Duval-Distin and colleagues. And in this patient, at a reappearance of PTC1-2, that's a very deep block, a low dose of Sugammadex has given. You remember the recommended dose would be 4 milligrams. What happened in this patient after giving 0.5 milligrams per kilogram? A complete, nearby complete, it was not 0.9, but close to 0.9 recovery of the TOF value occurs, and after that it goes down again before recovering completely after giving, in some patients they have given Neostigmine, I think in that one not. So how often has this occurred in that dose-finding study? Again, it was PTC1-2, the recommended dose is 4 milligrams. And you can see from that table 3 patients with a dose of 1 milligram per kilogram and 2 with a dose of 0.5 milligram per kilogram had an incomplete, that means a residual curization, or a new curization, a re-curization after having a complete recovery. The first 2 ones have been recovered completely, but after a time of 3 or 7 minutes, they again decreased with their TOF ratio. I think it's important to note that this happened within a period of 10 minutes, and it's also important to note that it happened in doses that are definitely too low. Less dangerous, I feel, is if the patient is not completely recovered either. So you see it during the recovering process, and of course, you have to give an additional dose too. So there is one simulation in the literature that shows about the reasons for these Re-Curarization effects. And this has been performed based on the data out of the list I have shown you. Elevate has published it from Groningen in the Netherlands, and he has shown that, again, in a scenario of PTC1-2, you don't have an effect with 1/4 milligrams. You have probably an effect of Re-Curarization with the 0.5. These are the data shown from that patient, and this is the modeling. And if you go up to 1 milligram, then this effect most probably disappears. And what are the risk factors? Again, the risk factors are definitely a deep block, high doses of rocuronium before reversing, low doses of Sugammadex, 1/4 or less of the recommended dose, and from a kinetical point of view, high Sugammadex clearance. That means Sugammadex goes out by renal clearance very fast, but a low rocuronium clearance by hepatic failure, for example. This scenario can lead to such a situation, and high Sugammadex clearance again with a long-lasting high rocuronium redistribution. These scenarios may lead to such an effect, but again, beside this one simulation so far, no data are available about this risk. And I think this manuscript written by employees from MSD, published in the British Clinical Pharmacology, perfectly shows the pharmacology behind the rocuronium Sugammadex interaction on the one hand and the clearance of the other one. And it becomes clear if the complex of Sugammadex and rocuronium, but also Sugammadex, is excreted very, very fast, it's theoretically possible that the free and complex Sugammadex rocuronium still is not down, and if those lines may cross in the late future, then reoccurrence of a block can appear. There are some reasons for thinking about that. The first is the dose of Sugammadex, of course, must be high enough in order to avoid that. That's the one thing. And the other thing is the risk is definitely dependent on the amount of rocuronium available in such a patient. If you give Sugammadex at, let me say, a TOF of 0.5, then the time of a normal recovery would be about 30 minutes. And in that time, 2.5 hour Sugammadex elimination would never reach this crossing point. So again, this is not investigated so far, though it's a risk known by experience, but not investigated in detail. So since we are at that pharmacokinetic process, I am focusing one time on a very curious situation. We have learned that the most important problem from the interaction between Sugammadex and rocuronium is that Sugammadex may disappear too fast. So if Sugammadex would disappear a little bit slower, this reoccurrence of a neuromuscular block never would happen. The one and only scenario in which Sugammadex is longer available in the patient is the patient with renal insufficiency because clearance goes down. And exactly in these patients, Sugammadex is not allowed to be administered. So you can see Sugammadex in renal failure patients. These are patients by Stahls investigated with a clearance between 0 and 30. You see the long median resistance time of 48 hours, pretty fine. Whatever happens with rocuronium, if only one molecule will appear in the plasma, it will be captured by Sugammadex. So a very good situation. And of course, The clinical part of that study show that Sugammadex is perfectly working in those patients too, but again, it's not approved and it's not allowed, even it is not allowed in Europe too. So, coming back to the risks and to the regulatory process, this study has been performed in order to address the question if Sugammadex will result in a relevant bleeding due to this minor increase of INR and APTT. This was a scenario in which we had to do. Sugammadex has given in a very high dose in order to increase the risk of bleeding, and it has been given in patients receiving any anticoagulant before surgery. With other words, the risk for seeing bleedings was increased in order to make the signal better to be seen and in order, again, to reduce the number of patients. And what we've done is in that study, Sugammadex was compared to usual care, and neuromuscular monitoring was not recommended in that study, though. That means Sugammadex has been also given in patients who most probably would not need any reversal drug. With other words, if there would be a risk of post-operative bleeding in the first 24 hours, it should have been seen. And the results, I think we can focus only on the first line. The results of bleedings within the first 24 hours in usual care in Sugammadex was comparable, or with other words, there is no increased risk. Also, a minor increase in APTT and INR has been shown again. Hypersensitivity. I was not part of that study that has been forced by the FDA, so I cannot give you primary results so far. I got a cold yesterday in the aircraft. The FDA has concerns about cases of suspected hypersensitivity. And ask for additional studies. The unsolved question is, first, has this seldom effects any effect on a bigger patient population? And if it is allergic, make repetitive applications increase that risk? Nothing known so far. And again, the mechanism is unknown, which is a problem for understanding of this. I can give you no clinical study that answers these questions. I know the study has been performed and I'm waiting for publication too. But I can give you some information from the worldwide experience with that drug. About 3 million applications so far have shown 2 to 5 hypersensitivity reactions in 100,000 patients. Patients who had used Sugammadex, but there is no clear relation between Sugammadex. But again, it may be 5 of 100,000 who have this problem, and none of that patient had any severe problem, or with other words, I cannot understand how a study must be performed in order to answer this question to allow FDA to approve the drug. I think at the end they have to do it without a response to that, because how to study such a seldom event? I don't understand how that can be done. Okay. The options. The options has been developed in about 6 years in many of the German hospitals, and I can show you the options within 3 algorithms based on the following assumptions. neuromuscular blockade improves intubating and surgical conditions, we have to use them. Residual neuromuscular block is hazardous if not recognized, and if not treated. We recommend neuromuscular monitoring because it's the best practice to measure neuromuscular function, but we have to accept that we are not able to convince the complete community to do it from now to tomorrow. So we have to find solutions too. But every solution must be quit within 10 minutes because that's the time we need to recover from the rest of anesthesia, from propofol or sevoflurane or whatever. And the sixth one, again, the management must be done in the same 10 minutes. The three scenarios are as follows. This is the one people are working in. If you decide 10 minutes without any neuromuscular monitoring, if you decide not to reverse, which people in Germany do, breathing, muscle function tests, whatever, extubation, and after that, a very, very thorough examination of muscle function again is clinical reality. That means most important is the swallowing function. Only if swallowing function is restored in our hospital, anesthetists are allowed to give the patient to the PACU people. If you decide reversal, we are fixed on spontaneous breathing in order to allow neostigmine. Maybe this is one of the other reasons not to use neostigmine, because neostigmine is an indirect cholinesterase inhibitor, an indirect antagonist of neuromuscular blocking agents by inhibition of the cholinesterase. You have the problem with the ceiling effect. If the complete cholinesterase activity is inhibited, a TOF of 0.9 is not completely restored. In this tissue board experiments, I think a well-known ceiling effect behind. So we are only allowed to give cholinesterase inhibitors in spontaneously breathing patients, or if monitoring, this is not relevant in that scenario. So with other words, you don't have a solution, and this is the option one. If you don't have a solution in patients that are not breathing, or there is a contraindication for neostigmine, Sugammadex is a solution, is an option, and this option is very clear. If the patient is spontaneously breathing, you need 2 milligrams, and if the patient has no spontaneous breathing, but the last dose of Rocuronium is more than 50 minutes over, then you have to give 4 milligrams, and of course only Rocuronium can be reversed. So then you have an option to avoid these investigations in the PACU, because it has been shown that this dosing allows complete recovery in more than 99.9% patients. So the next scenario, if you're using qualitative neuromuscular monitoring, the problem is that the qualitative neuromuscular monitoring is only able to show a residual block, but not to exclude it. Murphy has shown that only the quantitative monitored people in the PACU are really completely recovered. The tactile monitored ones have some patients with an incomplete recovery, and this is a reason that the residual neuromuscular block can be identified but not excluded by qualitative monitoring. So again, what we need is the muscle function test, at least in our hospital. And with other words, I had to go to you. So with other words, we have to go for reversal. We have to go for additional issues. Again, here, the ceiling effect I have mentioned just before, and the consequence is that if you have not a reoccurrence of the T4 count of 4, or you have any problems with neostigmine, you need an option, and again, the option is Sugammadex. Sugammadex can be applied in patients that have not recovered to TOF count of 4. The dose recommendations are again the same. Reappearance of T2, 2 milligrams, PTC1, 4 milligrams, but only if you have rocuronium. If not, it's not possible. And then, if you're going that way, you again can avoid the complicated clinical investigation process. But what happens in my most favorite scenario? Most favorite because quantitative monitoring may be AMG or EMG is used. What's the difference between quantitative and qualitative monitoring? I think it's an important difference because you got values, not only qualitative, you got quantitative values, and if a TOF is over 0.9, you definitely can exclude a residual block. And even if you do it on that way, and if you have a TOF over 0.9, then you can again extubate the patient without making such a difficult investigation. And more important, you got those recommendations not only for Neostigmine, I will not show it because my item is Sugammadex, but those recommendations, of course, are PTC1, 4, and PTC2, but the not recommended doses can be investigated, at least in such a scenario, and we can find if at reappearance of T4, for example, or at TOF over 0.2 and TOF over 0.5, in a bigger population, we are also able to completely recover. I can tell you, in such a scenario in our hospital, we have definitely increased the use of Sugammadex. We are just around 30% of our patients treated with neuromuscular blocking agents now receive Sugammadex. We use the complete tableau of those recommendations. And by the way, we did not increase the costs because we have stopped using Rocuronium, which, by the way, I think is not available for you, which is a very expensive drug. So I think based on such a algorithm, Sugammadex is a very important tool to improve our practice, and I think this is the most important option of this drug for us. Sugammadex, but not Neostigmine, allows reversal of each depth of a rocuronium or rocuronium-induced neuromuscular block, even without neuromuscular monitoring. I would not recommend it because then you have to give every patient Sugammadex, and I think even in your country it would be a problem to give each of the patient this drug. We are definitely not able to do it. Using rocuronium and Sugammadex, on the other hand, allows you to taper the neuromuscular block along to the surgical needs, and you will ever have an option to come out within 10 minutes. And finally, from the clinical experience we have done in Europe, Germany, or specifically in my hospital, Sugammadex does not increase the bleeding risk, and Sugammadex has nearby no side effects. After 6 years of use, I have never seen any hypersensitive reaction. Thank you so much.